This is part 2 of chapter 33 covering pediatric medical emergencies. So, as a refresher for that patient assessment, any breathing rate greater than 60 breaths per minute should be raising those flags. Checking that mental status, is it normal? Remember that pediatric assessment triangle of appearance, work, or breathing, circulation. So any kind of changes in those of slowing irregular respiratory rates, cyanosis, decreased muscular tone, poor perfusion, decreased heart rate, just poor general appearance, raising flags that something's wrong. Respiratory disorders are the likeliest cause of cardiac arrest in a child, second to trauma. So trauma, number one reason why kids die. Respiratory disorders is reason number 2. So with that, it's very, very essential that you are paying very good attention, doing very good assessments, and being alert for any kind of signs of respiratory failure. There's a number of diseases that affect the pediatrics in terms of difficulty in breathing. Anything from simple as colds and allergies to more stuff like epiglottitis, RSV. So the role of that EMT is to be able to recognize and identify stuff and intervene before it becomes life-threatening. Upper airway disorders affecting the mouth, throat, and larynx. This is basically foreign body obstructions, trauma, then resulting in obstructions, swelling from burns, major affections. Most commonly upper airway stuff identified with stridor, that high-pitched squeal that you'll hear without a stethoscope, difficulty in speaking, a seal-like barking cough, any kind of raspy sound other than that normal high-pitched squeal of kids. So differentiating between an upper airway and a lower airway problem. So the lower airway is going to affect the bronchioles and the alveoli. This can be things like asthma, pneumonia, bronchitis, and you're going to assess this with the difficulty in breathing and wheezing or rhonchi, just bad lung sounds. One respiratory disease, croup. Generally this comes with a mild fever and some hoarseness. This will be that loud seal bark cough. So croup, the big indicator for it, that seal bark cough. Also patient have difficulty in breathing, restlessness, and can be pale and cyanotic. With epiglottitis, this also accompanies a sudden onset of high fever and painful swallowing. Since it is very painful for that kid to swallow, they will be drooling profusely. Because every day we swallow our own saliva, but when it hurts to swallow, the saliva is just going to run out your mouth. They'll a lot of times be in a tripod position, and they'll try to remain really still just because swallowing, moving their neck, everything hurts because known medical terminology, itis means inflammation, so it's inflammation and swelling of the epiglottis. So in that upper part of the airway, swelling, it's sore, it's irritable. If you look in her mouth, you'll see that it's red and inflamed and nasty, and they'll appear much more ill than a child with croup. A child with a fever can be a really serious condition. Since kids, as we said before, are basically a big house with an inefficient furnace, their body doesn't regulate temperature well. So kids, when they get upwards of 102, 103 temperatures, can be very prone for seizing. So generally seizures in pediatrics, the number one cause is due to high fevers. So depending on protocols in your area, what they allow, there's generally a fever range of when you become aggressive, trying to cool them down. If you are going to attempt to cool them down, remove her clothing, Cover them in a tepid towel, not ice water or anything like that, just a cool air towel, placing it over their head or in their groins and armpits to try to get them cooled down to naturally break that temperature. But a kid's having temperatures of 99, 100, you know, if you have a fever, that's a sign of infection, so it's a natural response from the body. So basically just keeping an eye on the patient, monitoring them, and following the local protocols of what they allow and taking good, accurate temperatures. If they do have a high fever, transport if they definitely have suffered a seizure, so you got to figure out where that fever is coming from, what's causing it. Most generally, you take a pediatric patient to the ER. The first thing they do is look in their ears to see if they have an ear infection. But if you're going to try to cool them down, as I said, just tepid water on a towel, sterile water, put it on a washcloth over their head or in their groins. Try not to get don't get too aggressive. Don't submerge them into ice water. Don't put rubbing alcohol on there to cool the patient. That's an old wives' tale. You put rubbing alcohol on there, that will dissipate their body temperature and can make them hypothermic pretty fast. A child that has meningitis, and back to knowing our medical terminology of itis, meaning inflammation or swelling, and meninges, so inflammation and swelling of the meninges, which are a membrane layer that surrounds the brain and spinal cord. So they're inflamed, swollen, causing pressure and issues to the spinal cord and the brain. So good assessments on these patients. So that you may have to do anything from as little interventions as just giving oxygen to doing CPR. And especially kids, be alert for seizures because this is going to be pressure on the brain. So you may note in infants, if they still have fontanelles, that those could be bulged out from essentially the brain swelling and transport immediately. So if a kid's, another sign is kids with a stiff neck, because the neck is, the meninges in the neck are swollen, so it'll be really rigid and they won't be able to move their neck much. They'll have a high fever, altered mental statuses, just a wide range of things. So if you encounter any kid with diarrhea and vomiting, this can be very, very serious. So especially if they are vomiting, protecting that airway, giving oxygen, checking for signs and symptoms of shock, of tachycardia, poor capillary refill. Because you're probably, a lot of kids are going to be able to check capillary refill because blood pressures in little kids you can't do and are not accurate anyways. So if you see poor perfusion, tachycardia, contact medical control for sign of shock and alert ALS because they could have depleted a lot of their volume. If your protocols allow, trying to give the kids some sips of clear fluids, chipped ice, just fire protocols, whatever they may allow, and transport immediately. If a patient's had a seizure, basic comfort measure stuff, making sure the airway stays patent. Put the patient on their side if you can, if there's no spinal injury, and be alert for vomiting. Afterwards, giving oxygen and just keep an eye on their mental status and breathing. And also peds, check their glucose levels. A lot of times that their blood sugar can drop even if they may not have a diabetic history. Something could have happened. So back to if they've had vomiting and diarrhea, their blood sugar could drop too. So check out blood sugar to make sure it's not low. That's not the reason that they may have seized. If a child has an altered mental status, do some detective work trying to figure out what could have caused this altered mental status. Be alert for any kind of mechanism of injury, whether it was truly trauma or abuse, anything. Just put on your detective hat, check the environment to see if you can figure out what has possibly caused this. The good background history, the sample, OPQRST, trying to figure out everything going on with this kid. Looking for even other things, signs of shock, tachycardia, poor perfusion, slow capillary refill, evidence of any poisonings, and seeing if there's any history of diabetes or seizures. because sometimes in little kids, seizures doesn't always mean that they're doing the kicking chicken. I have seen pediatrics where their seizure is they just stare off into space. Also, always check blood sugar in an altered mental status ped. If they do suspect poisoning or confirm poisoning, airway and possibly oxygenate and ventilate if need be. Contact your poison control center or your medical direction, and if allowed, give activated charcoal, and then transport immediately. If you have a drowning patient, provide CPR the same way you would as if it is just a regular cardiac arrest, but keeping in mind of spinal immobilization, protecting against hypothermia. Wrap them up in a bunch of layers, get them warmed up while you're doing CPR if need be, and transport. With SIDS, that's basically the classification of a child died and nobody knows why. So there's just no rhyme or reason to why they died, they just did. So you're going to treat this patient just as you would any other cardiac or respiratory arrest and perform resuscitation efforts unless there's obvious signs of extended death like rigor mortis, lividity. If you are going to work that child, do so while you're transporting them. Do not work a pediatric arrest in a house. Transport. If you do not have ALS with you, request ALS immediately and give emotional support to those parents. As I said before, the parents can help or hinder your assessment and treatments. So if the baby has died, don't ever do any kind of subjective things or opinionated or blame the parents. Sometimes it just happens. So part of your big job on scene is if the baby is definitely dead with rigor mortis, lividity, things like that, is providing emotional support for the parents and probably more likely your partners as well. So now we'll talk about some pediatric trauma emergencies. During motor vehicle accidents, be sure to always examine the car seat that the kid is in and any other kind of vehicle indicators you may see. So checking out that car seat, seeing if it sustained any kind of damage, if you can see any other material objects in the vehicle that could have struck the child or anything the child could have struck, because not always are kids in the appropriate kind of car seat. So some injury patterns go with them. They got those big old bobble heads so they can be propelled forward side to side. So you just imagine a true bobblehead on the dash of a car that's been rolled over. So this kid's big head don't have a lot of muscles in her neck, and it can be very damaging to the head and the neck. Also with that head, if they get knocked out and the head falls forward, they can cause respiratory arrest secondary to a head injury. The chest, less developed, so it's more elastic, more tender. There's not as much protection for those organs and everything within that chest cavity. In this illustration, you can see that with those soft ribs, all the organs and vessels, it can be damaged. So basically anything from the esophagus all the way down to the diaphragm. And that includes your heart, your lungs, your liver, your spleen, everything kind of tucked up in those ribs. Your major arteries and vessels can also sustain damage. When assessing the abdomen, watch the diaphragm while they're breathing to make sure that you kind of have equal movement of the diaphragm in there to make sure there's no diaphragm injuries. Within the abdomen can be a site of hidden injuries, since a lot of internal injuries are internal, so you can't externally see them, at least hopefully not. And distension of that abdomen can be an indicator of those hidden inside injuries of internal blood loss. If you do have distension of the abdomen, it could interfere with artificial ventilations due to limiting the movement of the diaphragm. And then also keep an eye out for any kind of vomiting. If they damage some vessels, they could be spitting up blood, different things like that. And all the extremities, you're getting a manjos the same way as you do adults, except the only difference really being is be sure to check capillary refill in all extremities of all pediatric patients. One way that you can immobilize a kid instead of putting them on this huge backboard when they only occupy 10% of it is you can put a ped into a KED and you'll just wrap them up. So the head part would still go over the head as it does on an adult, but the torso part is going to go and secure the lower extremities, the waist, and the abdomen area. So in those buckles, they're going to be too long. So just take tape and wrap them in there, tuck them in there like a burrito. With burns, identifying those priority patients, anything burnt to the hands, face, feet, genitalia are all considered severe burns. Cover those burns with a non-adherent sterile dressing and keep an eye on our ABs and Cs and transport immediately. With shock, it can be caused from a variety of things, something as simple as diarrhea and vomiting all the way through severe trauma. It can also go into the really rare situations such as cardiac related, but generally most of those are underlying conditions that are known. Allergic reactions, poisonings, multiple things can cause that shock in infants. So that high heart rate and poor perfusion is signs and symptoms of shock. So you need to request ALS immediately and transport the patient to the local facility. Also, when you're caring for the shock, prevent heat loss. That's one of the biggest things you can do for those kids, is to keep them warm, to keep their energy levels up, to help with the body's natural compensatory mechanisms, and controlling any kind of bleeding you can see, and oxygenate by flow by. A tough situation you may have to encounter is child abuse and neglect. So there's various types of abuse, whether it's psychological or neglect or physical or sexual abuse. So that's psychological, just kids seen some bad things, just been exposed to a variety of awful things. Neglect, that's kind of a vague thing where it could be subjective, where some people may think that not bathing the kid every single day is neglect, where some people may think, well, a bath every 1 or 2 weeks is fine. And then physical abuse, those are pretty outward signs generally, as well as sexual abuse. The difficult things with those is the way that the kid is exposed to the 911 system. So a lot of times it's not parents calling and say, hey, I just abused my kid. It's sometimes you're finding the kids in the later stages and the parents are doing something that may be trying to cover it up. So some indicators of possible physical abuse would be slap marks, bruisings, abrasions, any kind of bodily damage. Now, keeping in mind of no matter what some people think of smacking or whipping their kids, if you whip a child, it's not going to leave long-lasting marks. And bruises, all kids are covered in bruises. It's just where to look for bruises. If you see large bruises on their backs, their bottoms, those are areas you're generally not going to see bruises. But kids otherwise on their foreheads, their shins, their arms, they're bruised up all the time because they slip, they trip, they fall, they run into stuff, they're clumsy. So that kind of happens in abrasions, lacerations. Just trying to use some common sense of, well, was that a little abrasion because they just fell on the floor? Or is that something significant? How did this kid get an abrasion all the way up their back? And generally, most of the injuries you see on kids that are accidental are on the front side. Broken bones. Generally, kids don't break bones. They kind of bounce like basketballs. So kids who have major broken bones, a lot of times when they go to the hospital, unless it was easy to identify they were in a car wreck or something, if you just call and say the kid fell off a couch, he's got a broken leg, a lot of times those kids are going to be investigated by Child Protective Services just because that just seems a little off. And that ties into any of the other major indicators you see, like bite marks, burn marks, any kind of head injuries, anything that suspects that may raise a flag at the ER. They're generally going to get investigated. So here's a picture of some suspected child abuse. You can see the bruisings on the buttocks in various areas. So if you just had one or two little bruises is one thing, but when you see bruises in several areas, that is abuse. So when you're leaving bruises on kids on their butt from whipping them because they did something bad, that's crossing the line to child abuse. And bite marks, I'll note, if you've never been around kids, other little kids bite one another, and that happens. But if you see bite rings that appear to be from a mouth much larger than a child, that they're very deep, an indicator that the child may have been bitten by an adult. So some indications that might lead you to suspect that the adult or parent or whoever around is an abuser. If there's just really odd levels of concern about the child, if they have any kind of inappropriate emotional responses, if they have trouble controlling their anger, could make you maybe suspect that controlling that anger towards you is probably about the same anger they may have towards that child. If they just appear to be weird, if it give you that gut feeling that something might not be right, or if such things as in deep depression, or if they appear to be under the influence or something, can be very big indicators. Or if the story they're telling you just doesn't quite add up, they're repetitive with the story, but it's not exactly the same. Those indicators that they're lying, that something is wrong, that maybe the kid didn't really just fall off the couch, that maybe they were thrown against the wall or something. If so, you can do a little bit of detective work and be asking questions. Try to ask detailed things if you suspect anything, but just don't confront the parent or the adult about being an abuser. If you do suspect or you find that you are involved in a abuse case, try to provide good support to the patient and preserve any kind of evidence. So if you suspect that they've been sexually abused, try to discourage them from going to the bathroom. Don't let them drink anything. Try to, if they have to remove their clothes, try to keep those in a bag to be giving to the hospital and police for investigation purposes. So what your role is going to be in the suspected case is trying to gather information without being a full-on detective and not doing accusations. So trying to get that child aside from the adults to see if their story adds up. And then by law, you have to report any kind of case of abuse to the ER or police, or you can do it through the medical direction. But by law, you must report it, that you suspect it. And using those terms of that you suspect it or possibly. And don't do that to the parents because it could make the scene very unsafe. So do that with hospital staff, police, your supervisors, or your medical direction, or if your state has a state of child abuse reporting hotline, such as West Virginia does, contact them immediately. So now we'll talk about some children with special healthcare needs. So a lot of times the special challenges you may encounter are going to be chronic conditions that a lot of times were developed from birth, such as premature infants that have lung disease. The lungs are one of the last things to form within the fetus. So if that kid was born before the lungs were fully developed, they can end up having some major lung diseases chronically for the rest of their life. Also, heart diseases and neurological diseases. Those are generally going to be a lot of things from birth. A lot of kids and are young in ages don't just randomly develop heart diseases or neurological conditions. Those are all from birth. Tracheostomy tubes, possibly one thing you may encounter. So complications with that, it's going to be generally obstructions. They get some mucus and a lot of stuff built up in there, and they can become obstructed and require you to suction them and clean them out. They can also just have infections secondary to that, or they become dislodged or have air leaks around them. So you see in the picture a baby who's got a tracheostomy. So they're not really breathing through their nose, through their mouth. They're breathing through that tracheostomy tube. So you can imagine that your nose is supposed to filter and humidify the air. If you don't it's bypassing all that, going through the tracheostomy tube, there's going to be a lot of mucus and dryness and stuff built up. And it's a hole punctured through the skin, so it can end up causing a lot of infections. If a child's on a home artificial ventilator, you may just have to simply disconnect the ventilator and artificially ventilate them if there's complications with that ventilator or something else has went awry. If they have central lines, big thing there is just going to be infections and bleeding, or any kind of the line has become dislodged. So basically just have to do bleeding control and just do good assessments on to see if you see any redness or spotting to see if it could be infected, and then transporting to the hospital. With those things, not much you can do pre-hospital wise except good assessments. GI tubes, these feeding tubes that go straight into the stomach of the babies. Sometimes when kids are born, they may not have a thrive to live for whatever reason. There's some kids that just when they're born, they don't want to eat, do anything, so they may get these GI tubes put into place to feed them because they just won't want to feed themselves. So kind of the same thing. There's the central lines and the trach tubes. Big thing's going to be redness and infection, causing other secondary stuff in this kid. Also with these, they can become clamped or dislodged. So again, just good assessments, transporting to the ER. With a shunt, basically what a shunt is, if there's, say, extra fluid that just randomly builds up on the brain, they'll put this shunt in that basically creates like a gutter. So the extra fluid drains off through the shunt and gets put into the GI tract. So with shunts, just checking A, B, C's. If they have fontanelles, be making sure that they're not bulging or sunken in. Give oxygen and do good assessments and transport the patient. So psychiatric effects on the EMS provider can weigh very heavily. So don't be a tough guy on bad calls you've had with pediatrics. So you can seek expert consultation with this stuff, talking with your coworkers or professional counselors. Hopefully your agencies, if you're ever exposed to any kind of bad scene, especially a pediatric call, that they provide you with critical incident stress debriefing, CISD. So where they can bring in counselors and talk to you about handling this, because it's just natural human responses for pediatric calls to affect everybody.